webinar sponsored by Canon Medical Systems on incorporating cardiac CT into your standard of care for the evaluation of chest pain. Today's speakers will be Drs. Marcus Chen and Catalin Loghin. A few housekeeping items before we begin. We will be answering questions after the presentations. Please type any questions that you may have in the chat feature, which can be located by the speech bubble at the bottom of the screen. We will also be recording today's webinar, so if you miss any section, you'll be able to review at a later date. You'll receive a link to the recording via email tomorrow. Okay, let's get started. We will begin with a presentation from Dr. Marcus Chen. Dr. Chen is the Director of Cardiovascular CT at the National Institutes of Health located in Bethesda, Maryland. He will be reviewing some of the most difficult to image CT cases and will discuss using the latest CT technology to image those outlier patients with the highest heart rates, plaque burdens, and comorbidities.
Thank you for the introduction and for the opportunity to share my experience how to incorporate cardiac CT into the standard of care of chest pain using Canon and Aquilion technology. Recently published 2021 multi-societal guidelines for evaluation and diagnosis of chest pain is very comprehensive. And for the first time, cardiac CT now has a class 1 indication. In the next 20 minutes or so, I will show you how Canon and Aquilion technology can be incorporated to use these guidelines. If you're not familiar with the guidelines, this is the take-home message, which has an easy mnemonic, chest pains. But what I'm really going to focus on is two parts. One of them are the pathways, the clinical decision pathways, and also helping you identify which patients are most likely to benefit from additional testing. I'm going to walk you through the evaluation for a suspected ACS of someone at intermediate risk with no known coronary disease. So the first question is whether or not they had prior testing. If they have not had prior testing, then you come to a decision point where you have two options. You can either have stress testing or you can have perform a cardiac CT. And cardiac CT is, again, it's the class 1 indication with the highest level of evidence in A, where it can be used to exclude significant coronary artery disease. Now, let's take someone who has known coronary disease and intermediate risk. So if they've had known non-obstructive or less than 50% stenosis, again, you have a decision. You can proceed with cardiac CT, or you could have do stress testing. However, you should remember that the test choice should be guided by the local availability and expertise. The guidelines help you choose the right test, whether someone should have CT or have stress imaging. And in general, people, younger patients age less than 65 may favor CT if they had a prior inconclusive functional test, and if you want to rule out significant disease, that all favors CT. But probably the most important feature is that what is available. And if high quality imaging and high and expert interpretation is available, then that would favor the use of cardiac CT. The NIH and Canon Medical have been working together for the past 12 years. And this relationship started in 2009 when we invested in wide area detectors with the original Aquilion 1. About every 3 years, we have upgraded our CT technology to the newest flagship scanner. And last year, we took installation of the Aquilion 1 Prism, which has spectral capabilities. Now in 2021, we've been working with Canon Medical to improve image reconstruction with now super resolution images. So allow me to highlight the experience using Aquilion 1, which has whole organ coverage and 320 detector rows. So with wide volume coverage, you can image the heart within one heartbeat to image just the coronary arteries or you can image throughout the cardiac cycle if you want to dynamically visualize the heart valves or the myocardium for wall motion. If you don't have a wide volume CT system, you can encounter misalignment or stair-step artifacts from imaging all over several heartbeats. So here's an example of a left anther descending, which is misaligned, and this makes interpretation more difficult. If you don't image the heart at one time point within one heartbeat, there can be beat-to-beat variability, and the breath hold times can be longer, which, if the patient can't adequately hold their breath, can cause chest wall motion artifacts, which really exacerbates any sort of alignment issues. So with a wide area detector, you can image the whole heart and coronaries within one heartbeat with temporal uniformity. Everything's imaged at the same time. There's no misalignment or stair-step artifacts. And since everything's imaged at one time, you can better translate this anatomy into physiology with perfusion or with FFR CT. Now, normally a calcium score of more than 4,000 would be a nightmare to read. However, if you've got temporal uniformity, if you don't have any of these stair-step or misalignment artifacts, you can interpret these studies without a problem. So here's a patient who has a calcium score of 4,397, and the images off an Aquilian 1 are completely diagnostic, and I can confidently exclude obstructive coronary artery disease. Now, the Aquilian 1 has a fast gantry rotation time of 275 milliseconds, which can stop cardiac motion. Now, here's a patient I scanned. So don't you hate it when the patient starts screaming during the contrast injection? Well, this patient, due to the warmth of the contrast sensation, being injected at 5 cc's a second, wasn't really expecting that and starts screaming. However, the images are completely diagnostic. So, so this was a single heartbeat scan, and there's a little bit of motion artifact despite the heart rate of 94. But again, I can exclude coronary artery disease very confidently in this patient. Now, the Aquilian 1 also can deal with arrhythmias. Let me show you that. So the system has built-in arrhythmia detection, where if it detects a premature beat, it will hold the X-ray exposure and wait until the next beat to go ahead and expose the patient. So let me give you an example. So atrial fibrillation cases are always challenging to scan. However, the arrhythmia detection greatly makes it easier to read these images. So here in this example, there is an early R wave. The scanner actually stopped the X-ray beam, and with the next beat went ahead and exposed at the proper time. The radiation dose is higher because there's a longer exposure, actually 2 exposures in this case. However, the exam is completely diagnostic. So here's a case from last week. Patient with atrial fibrillation with widely varying RR intervals. The heart rate during the scan was 124 beats per minute. However, the scanner was able to stop cardiac motion without any motion blur. Image quality like this is only possible with a wide area detector CT. Furthermore, the CT system can save you time by automatically determining which is the best phase to interpret. And this phase is the phase that has the least amount of cardiac motion. So I've observed that even in slow heart rates, as in this example, a heart rate of 59, you can still have motion artifact depending on what phase of the cardiac cycle you're looking at. However, the system will automatically choose this best phase for you to interpret, and this saves me time as the reading physician. So I've worked with Canon Medical to help validate new technologies, and one of them is cardiac CMAR, which is single energy metal artifact reduction. So metal artifact reduction was originally developed to remove beam hardening artifacts from large metal objects such as hip prosthesis, but now it's available for cardiac applications for ECG gate exams. So here's an example. So it's not uncommon for patients who have a pacemaker or defibrillator that the right atrial lead can obscure the proximal right coronary artery, as in this example. However, if you apply the metal artifact reduction technology, or CMAR, it removes this beam hardening artifact, and now you can evaluate the proximal right coronary artery. Now, this technology also works for other dense objects, such as bypass surgical clips or sternal wires. Now, to go back to the guidelines for the chest pain guidelines, in patients who have had prior bypass surgery, it's a class 1 indication to use cardiac CT for further evaluation. So CMAR can help with evaluating patients with bypass grafts. So here's an example. So here's a Lima graft where there are 2 artifacts from the clips. Now, if you apply CMAR technology, now you can confidently exclude any significant stenosis in the graft. And let me just blow this up for you to make it easier for you to see. So on the left is standard image reconstruction, and on the right is where we use the metal artifact reduction technology. So Aquilion-1 also has artificial intelligence deep learning reconstruction, and I helped in the development and validation of the reconstruction. So here's an example where deep learning reconstruction, with its ability to significantly reduce image noise, can really help the patient. So this is a morbidly obese patient, BMI 55. She's huge. She's not even 5 feet tall, 274 pounds, and she had a equivocal nuclear spect with a possible anterior wall reversible perfusion defect. The deep learning image reconstruction reduces the image noise, and we're able to fully evaluate the left anterior descending and basically determine that the nuclear spec was a false positive, since there's no obstructive disease in this vessel. So going back to the chest pain guidelines, if you have a patient who has acute chest pain, intermediate risk, with no known coronary disease, if they've had prior testing, which was inconclusive or mildly abnormal, it's reasonable to get a cardiac CT. On the other side, if they've had no prior testing and then proceeded to have stress testing, which was inconclusive, it is reasonable, the class 1 indication actually, to go ahead and do a cardiac CT. I want to introduce you to a new evolving technology, which is super resolution deep learning reconstruction. This super resolution imaging is called Precise IQ Engine, or PEAK. And what makes it different is that the input data is based on standard resolution images with high noise, and the target is super resolution 0.25 millimeter images with low noise, and it does this in a 3-dimensional format. And let me show you what these images look like. On the left are conventional images. On the right are super resolution images. And let me just blow this up for you. The super resolution images are like wearing glasses for the first time. You're better able to see things. There are things that you see now more sharply that you really didn't appreciate before. Now going back to the guidelines, you may ask, how about stents? Well, cardiac CT is reasonable to perform in patients who have a stent greater than 3 millimeters. And I want to share with you what these super resolution images look like with stent imaging. And here's an example, right? On the right are super resolution images. And now we're better able to visualize within the stent. We're able to see the individual stent struts, and we'll be better able to evaluate for in-stent restenosis with this new technology. Now, what I'd like to do now is kind of put all these different technologies together, and in my experience, with all these different technologies, you can consistently interpret difficult or challenging cases. When you use these technologies together, you can consistently give low radiation doses. My group has demonstrated that, and other groups have as well. And here's an example of an ultra low dose. This is 0.017 millisievert cardiac CT, which is this is done in someone who's not underweight. It's a BMI of 21, normal sized, 5'3", 121 pounds. It's a good quality image with good SNR, no artifacts. It's important that we make an accurate diagnosis. And in this patient, there's a very high-grade stenosis here in the mid-circumflex, and in the LAD, there's areas of calcified and mixed plaque, but it's non-obstructive. And when we look at the invasive angiogram, there's a very high correlation of what we see non-invasively by CT versus the gold standard invasive cath. So here's a difficult case that was referred to me. This is a patient who has a 7-centimeter aortic root requiring surgical repair. They attempted to do invasive angiography to clear the coronaries before surgery. However, the aortic root was so big they weren't able to engage the coronaries. So this outside hospital then proceeded with a cardiac CT. This was done on a 64-slice scanner. The heart rate was in the high 70s, and despite trying beta blockers, the study was basically non-diagnostic because of coronary motion artifact. So they sent the patient to me because they know I have a high-end scanner and can image difficult cases. But here's that same patient. We tried our best to slow down the heart rate. We could not get it below 80. So this is the scan at a heart rate of 80. And this was prospectively done, and I can confidently exclude significant coronary artery disease. So the patient proceeded with the aortic root replacement. So getting back to the guidelines, so the ideal patient to image with cardiac CT is if they have an intermediate pretest probability, if they don't have any contraindications, such as contrast allergy or clinical instability or impaired renal function, if they're less than 65 years old, if they've had a prior inconclusive functional test, and if you have available high quality imaging. These guidelines have a table to help you choose the right test. And for cardiac CT, they specifically mentioned elevated heart rate and heart rate variability. But overall, the Canon Quillian 1, I mean, in my experience, it covers every heart. With a wide area detector up to 16 centimeters, we're able to image within one heartbeat, which really minimizes any of the stair-step or misalignment artifacts. We're able to scan patients with higher heart rates and with arrhythmia such as atrial fibrillation. And we're able to do this safely with very low amounts of radiation, a median dose of less than 1 millisievert. Now, we also have new imaging technologies like the metal artifact reduction technology, or CMAR, to remove those artifacts from pacemaker leads or surgical clips. And now we have these new deep learning image reconstructions, or even the newer super resolution image reconstruction, which makes interpretation a lot easier, and we're better able to identify and characterize coronary disease. So thank you for your attention. This couldn't be done without my imaging team, and I look forward to answering questions either through the chat or through the Q&A at the end of the session. Thanks again.
Thank you for that wonderful presentation, Dr. Chen. Our next talk will be by Dr. Catalin Loghin. Dr. Loghin is a professor of cardiovascular medicine at McGovern Medical School at UTHealth in Houston, Texas. His talk will detail the uses of CT as a comprehensive modality to image the heart and the need for education and advocacy within the clinical healthcare system.
Hello everyone, and welcome to our webinar today. Over the next 25 minutes or so, I'm inviting you on a journey which will illustrate the elements required to build a truly comprehensive cardiac CT imaging program as it worked for us over the past decade or so. These are the elements which I think are integral part of any cardiac CT program. I call this peer, staff, protocols, education, awareness, and recognition. By staff, I mean our CT technologists. We all know how much we depend on them. They are the backbone of any program. Having an interested person who is passionate about cardiac CT is critical to the development of any program, and nothing would be possible without them. As well, by staff, I mean our collaboration with our radiology colleagues, which in our institution is exceptionally good. For the past decade or so, we have been collaborating and sharing the interpretation of studies and sharing our experiences and helping each other all the time. Over these years, I think this was also an absolutely critical part for developing a fully integrated cardiac CT program. Our protocols are important to delineate, and while every scanner will come with basic protocols, I think the addition of indication-specific protocols tailored to the needs of the particular community that we address is very important. We now have protocols which can address virtually any indication. We have protocols, including in our scanner, which address the requirements of specific clinical trials. And whenever asked, can you see this? Can you show me a picture of this? The answer is always, we have a protocol pretty much for everything you can think of if you want anatomical detail on a specific structure of the heart. We maintain flexibility in our protocols because every once in a while there's a special requirement. Somebody would like to see, for instance, the aortic root, but they're also interested in the aortic arch, and we open the window a little bit more. Or somebody wants to see some structures in the right heart, and at the same time to see this left atrial appendage thrombus, and we add the venous phase. Flexibility is important. I think it's also important to mention that diagnostic quality studies are not necessarily the result of the latest and greatest scanner. Earlier generation scanners can produce very high quality images, certainly of diagnostic quality, if not atlas quality, and one can rely on those and have excellent clinical results. Obviously, any of the protocols we implement aims to minimize the exposure to radiation. We have the benefit of using a 16 centimeter wide area detector scanner. It allows us to scan the whole heart in one heartbeat without moving the table. This leads to great reduction in artifacts, also leads to dose reduction, which we always appreciate. We tend to scan either prospective or retrospective, depending on the indication and the protocol that we use. and whenever we scan, we enjoy one characteristic for the wide area detector, which is providing temporal uniformity, since we acquire everything in one heartbeat. I think this is a critical component for the quality of myocardial perfusion studies, which I'll discuss a little bit later. Of course, high-quality images can be obtained with 6-centimeter detectors with a helical skein, maybe perhaps more motion artifacts at some point as we acquire over several heartbeats. The 16-centimeter wide area detector mostly is used for prospective scanning as long as the patient is with a heart rate of less than 75 beats per minute. We deal with a temporal resolution which is not ideal. It's 137 milliseconds. However, despite that, we see very few motion artifacts, and these typically involve the mid-segment of the RCA. As we know, it's the fastest moving structure of the whole heart. For the Texas population that we see, whenever we acquire prospective in diastole, we deliver a dose that averages 2 to 3 millisieverts. It's not that uncommon to see 1 or sub-1 millisievert studies, but they're not always and every day. Every time that we have a TAV, we will acquire according to the protocol that comes with this, but we always try to acquire prospective if we can. We enjoy the benefits of metal artifact reduction, and all the artifacts that result in this case from a pacemaker lead are reduced to hardly anything. In general, the cases we see, and they have a pacemaker, it's not a problem to interpret RCA or the circumflex artery at all. Very rarely this represents a problem. Of course, we are very excited about the advent of spectral cardiac scanning and the ability to generate iodine maps, either by rapid KV switching or with the advent of the new PCD scanner that's been recently approved by the FDA. I think the iodine maps have the potential to change the field of CT myocardial perfusion, and I'm so very much looking forward to it. Coronary artery disease represents approximately 2/3 of our cases. This is a distinct shift from what was happening only 5 or 6 years ago, when the majority of our cases were structural heart disease. By trying to promote the modality, cardiac CT capabilities for imaging coronaries in an environment where interventional cardiology is our traditional tool, and in an environment where we have a very strong PET center, was a challenge. However, now for each 2 coronary cases, we have 1 structural case. Obviously, everybody does calcium scoring and coronary angiography. That's the bread and butter of every program. Some are interested more and perform and use CT-FFR. Some have a great interest, like in our institution, in CT myocardial perfusion imaging. And furthermore, plaque analysis is also the subject of interest for other institutions, as I will show you. A whole lot has been said about calcium scoring, and I don't want to open again a debate whether it has a benefit in terms of reducing mortality in cardiac and coronary artery disease or not. I find it easier if I tell a patient that I'm going to propose to you a scan which is going to look at the calcium in your heart vessels, and think of it as a mammogram of the heart. That seems to be easier accepted, other than trying to explain the pathophysiology of atheroma and what the calcium role is, and so on. So typically patients understand mammogram, and if you tell them this is a mammogram of the heart, they accept the scan according to the guidelines for the asymptomatic patients. Because of the simplicity of the study, and because of the ability to perform this with earlier generation scanners, I think this is perfectly suitable as a modality for mobile CT units, part of a larger screening program which hopefully will develop for early detection of coronary artery disease. Within a few thousand cases, I have seen a handful of cases like this one I'm showing to you here. This patient has had typical angina when exerting himself, playing golf or tennis, had a couple of SPECT studies which were inconclusive, and finally was sent for coronary CT angiogram that showed just a punctate calcified atheroma. Calcium scoring would have been very, very low. However, this lesion in the left main was very concerning. Patient was sent to cardiac catheterization, which confirmed the soft atheroma, nearly occluding the left main. Patient was treated based on this, and his life was saved, I would say. Some argue that the dose currently needed to perform a coronary CT angiogram is so low that it's approaching the dose used for calcium scoring. So some would propose that for millisievert extra, why not get just as well coronary angio instead of doing calcium scoring first? Maybe the future guidelines will revisit this proposition. This is a kind of scan that we expect and we see basically every day. I have intentionally blown up the image so you can see the details of the vessel and how well you can see the lumen. This is not our best scan. This is not our worst scan. This is something we see on a daily basis. 1.2 millisieverts in an average sized person for a heart rate of 52 beats a minute, whole heart single beat volumetric acquisition. I would say it came out beautifully. We all have gone through the growing pains of early reading when we tend to overestimate the lesion, and we have difficulty, and still today, seeing through cardiac stents, seeing through lots of calcified lesions, and next thing we know, we send the patient like this to the cath lab, and the phone call comes back quickly. What were you thinking in my invasive angio? My vessel looks perfect or nearly perfect. Why did you send this patient to the cardiac cath? This problem still remains. Hopefully the spectral imaging is going to change that as well. But until that happens, I think we can use other tools like myocardial perfusion, respectively, or CT-FFR to delineate whether these lesions are indeed significant or not. Sometimes we see more than the interventional cardiologist will see. This particular patient presented with typical signs and all the evidence for acute myocardial infarction. Was sent to cardiac catheterization, and the result was angiogram is normal. 2 or 3 days later, his attending physician requests an MRI with a viability study, and that shows very nicely an anterior nearly transmural scar. And then the patient is sent to coronary CT angio, which shows clearly the culprit vessel that was occluded. And if you go back to the angiogram, you kind of see it faintly opacified here, but it was missed during the angiogram. We do have in our institution and enjoy having a CTO, a very strong CTO program. Our interventional cardiologists have grown accustomed to requesting coronary angiograms with the sole purpose of planning a CTO intervention. They know that we can deliver them information related to how big the vessel is, what is the length of the occlusion that they're going to have to deal with, whether the vessel is tortuous, whether there's calcification, or if they are collaterals, if sometimes we can see those collaterals that can provide a retrograde approach to fixing the lesion. CT-FFR has had a lot of data behind it over the past few years. It has been given, as you all know, quite a bit of importance in the most recent guidelines on chest pain evaluation. When it's normal, we see a result like this, where all the FFRs, based on the calculations, are above 0.8. Triple vessel disease will look like this, and obviously something we don't want to see every day. There's a whole lot of data to show that CT-FFR is very well correlated with the anatomical appearance of the lesion, like in this case, a complex plaque in the LAD, which leads to decreased FFR below 0.8 in the CT-FFR evaluation. It is important to note that compared to the invasive FFR, CT-FFR answers a different question. CT-FFR answers the question whether it's the cath or not the cath, whether it's worthwhile sending the patient to the cath lab or we can safely treat him conservatively. In contrast, invasive FFR answers a different question. Is this to stent or not to stent a lesion, which appears to be borderline on already existing invasive angiogram? Furthermore, I think it's important to realize that the agreement between CT-FFR and invasive FFR is not terrific, especially for the values we're most interested in. Like this graph shows, the agreement between CT-FFR and invasive FFR drops to somewhere 50 or even below 50, exactly in the areas of the FFR where we're interested, 0.7, 0.8. What would be an alternative to CT-FFR? I think there's a great value to CT, stress CT myocardial perfusion. There are multiple ways of doing this. There are multiple ways of driving the scanner, if you would. Mostly is done in a static or dynamic fashion for most of the literature existent. It's all based on trying to differentiate and trying to see the differences between ischemic myocardial attenuation and normal myocardial attenuation. This difference is not that great. It's only about 15 Hounsfield units, and it's illustrated here. Furthermore, this small difference between normal and ischemic myocardial attenuation doesn't last too long. It only lasts for about 8.6 seconds on average, obviously depending on the arterial input function. So timing of where we take the picture to capture the difference, the short-lived difference and the small difference between normal and ischemic myocardium becomes a critical issue. In our institution, we do static perfusion only. We acquire diastole. We try to get the timing right to be somewhere here. It's not always that easy. Other institutions practice dynamic CT perfusion, covering the whole cardiac cycle over several heartbeats with some inherent artifacts, as you can see here. It is important to know that, at least in my opinion, the wide detector scanners offer an advantage because they, again, ensure the temporal uniformity as the heart is acquired in one heartbeat alone, so that the myocardial arterial flow transit time is taken into account and doesn't create artifacts. The myocardial arterial flow transit time is extremely short. Blood comes in and goes out of the myocardium in about a quarter or half a second, again, depending on the arterial input function. So having temporal uniformity, in my opinion, is very important. This is how it looks like. In this case, we overlap the anatomical data with the functional data of perfusion. Blue is normal perfusion, orange is ischemic. This patient had absolutely no angiographic coronary artery disease, but was born with a nearly atretic LAD and diagonal system, and the anterior wall was ischemic during adenosine stress, which explained his complaints. Another patient, sometimes the anatomy doesn't help much. We can't see through stents. If you notice, the flow distal to the stent is not exactly the grade. The opacification is not quite there. Scan 2 is stress, adenosine stress. Scan 1 is rest. A small area, relatively small area of intense ischemia exactly in this territory. This area was exactly the same area that the PET scan in the same patient has seen, and the in-stent restenosis was confirmed by cardiac catheterization. Another example of a study which is representing some difficulty for the regular SPECT studies, balanced ischemia, a patient with triple vessel disease proved by invasive coronary angiography, resting images, adenosine stress images, hardly any ischemia at rest. The whole heart becomes ischemic during stress because of triple vessel disease. Perhaps a more interesting case, again, rest on the bottom, stress on the top. This patient presented with chest pain, and all the echocardiographic findings of Holcomb confirmed a gradient as well. No coronary angiogram, no coronary lesions at all by coronary angiogram. However, during adenosine stress, the whole heart became ischemic, especially the territory of the anterior wall. You can actually see the ischemic subendocardium versus the other segments which are better perfused. CT myocardial perfusion can be displayed and used in multiple ways of interpreting the data. We use transmyocardial perfusion ratio as our workhorse. Very rarely we look at the contrast maps of perfusion indexes. It has advantages which are undeniable. It's the only cardiology test that provides both anatomical and functional information on coronary artery disease. In one test, in an hour or less in our hands, for about 6 or 7 millisieverts. And so far in our more than 100 cases performed, some of them have had correlations with invasive coronary angiography, and so far I think we did pretty good. Nothing is perfect. We deal with artifacts every single day, and unfortunately we're still missing the CMS code for interpreting perfusion studies. We can only interpret the stress portion. There are limited training options still. I think we're lacking this, and this should be developed. And obviously, the availability of dedicated software is something we have to keep into account. Other institutions went in a different direction from CTFFR and perfusion. It's involving plaque analysis and morphology of the plaque and the components of the plaque. This is looking back at the old concept of vulnerable plaque, knowing that most of the acute coronary events relate not necessarily to flow-limiting stenosis, but instead relate to stenosis that are only 30 or 40%. So analyzing all the components of the plaque, like in this example, flown clearly, becomes important in identifying which plaque is most likely to generate an acute coronary event in the future. Either way, whichever way we look, all these elements of a coronary comprehensive analysis are present, from the basic quantitative CT angio, CT myocardial perfusion as the end event and end product, CT fractional flow reserve describing a single stenosis, or looking at transluminal attenuation gradients. The role of each of these modalities still remains to be defined in the future. In our facility, structural heart disease is one of the most important indications. Approximately 1/3 of the cases are like this, and TAVR is the one that is actually the most common. CT is obviously the gold standard for it. There's no question about that. Using a wide area detector scanner, we uses 3-phase variable helical pitch scanning in a single bolus with a single breath hold, one acquisition, very low artifacts, low radiation dose, low contrast dose, and reduced scans with typically very good vascular attenuation. A full TAVR evaluation can be extremely complex sometimes, or sometimes it's simpler. In this particular case, we determined also the aortic valve area quite accurately, and I know what the literature says about the agreement with echo, but that's not always the case. Sometimes we see quite significant discrepancies. We can calculate and come up with angles for deployment, even though this is done nowadays more so on the cath lab than based on the CT evaluation. This particular case had bypass and grafts, which are also analyzed. Also, you could see a patent stent in one of the SVG grafts. So, when all things look good and everything goes well, the sapien prosthesis from TAVR looks like this, a full 3D reconstruction showing it's fully deployed. Leaflets are nice and thin, they're moving, you can see them very clearly, no problem. When things do not go so well, like in this case, the prosthesis was deployed too high, the cells covered the left main, patient collapsed, was rescued and did well in the end after chimney stent was implanted and deployed in the left main urgently. Unbeknownst to the operator, even the RCA was actually within a cell of a sapien prosthesis, but it was not occluded. It looks like 4D CT is some sort of a science fiction tool, and we're getting these questions all the time. Can you do 4D CT? What is this 4D CT? What's 4D representing? And we tell that with everybody that essentially you can do this even with the previous generation scanners, and essentially there's a cine angiogram of all the phases in the cardiac cycle. I used an example with the Holt syndrome in this a Holt patient after sapien. You can see that one of the leaflets, actually 2 of them were covered with thrombus, and this one was completely immobile. It's very easy to do, and we're getting more and more requests whenever post-op we see high gradients by echo. We are very happy to hear a call from the surgeons. More and more cardiovascular surgeons send patients to the lab. In this particular case, this was a Percival valve deployed correctly and fully. Initially, looked like everything is more or less okay with the leaflets seen like this, but further exploration of the leaflets showed that 2 of them were completely thrombosed. One of them was getting there, and this explained the high gradients for this prosthesis by echo. A biological mitral prosthesis example, this was degenerated patient presented with echo, findings of severe, basically wide open aortic regurgitation. If you look at the biologic prosthesis orifice in diastole, it's about the same size with the orifice in systole. Basically, the valve was nearly stuck in one position and fully leaking. For TMVR, it gets a little bit more complicated. We look at multiple things, not the least of which we look at the possibility of a neo-LVOT obstruction. We calculate the automitral angle, we look at the automitral curtain, we look at the thickness of the septum. All of this data is collected to make sure that the planning for the procedure was right. When it doesn't go well, like in this case, after TAVR, TMVR was performed, systole or diastole, the prosthesis nearly touches the septum, and even in diastole, the LVOT was just a slit, as you can see in this image. LVOT obstruction happens in surgical valves, struts all touching the interventricular septum, and explain the gradients that were seen. Leaflets were perfect morphologically. We see for mitral valve things which are not necessarily seen easily in echo, even in 3D TE. This is mitral valve disjunction of the posterior leaflet. Patient was treated with a mitral clip after he had a TAVR as well. Sometimes surgeons are happy to see that patients referred to them might not necessarily be the best surgical candidates. A very large Casio score of a very prominent severe mitral annulus calcification also protruding in the posterior myocardium. Also, sometimes we disagree with the echo findings. This patient was referred for surgery as the Wilkins score for mitral stenosis was too high, not a candidate for valvuloplasty because of the calcification. But we didn't see calcification, just a very fibrotic valve with a little bit of commissural calcification here and there. Patient was sent in eventually for valvuloplasty. We have seen a few 10-9 valves like this one that accumulated thrombus. Patient did well, thrombus in the frame of the prosthesis. We would like to see more and more occluders studies. I believe that it's much better to study the appendage prior to procedure with CT rather than TE. We can see the shape of the mouth better. We can see the dimensions of the neck, how many lobes, very, very easily. And we can see a leak whenever it's present, even though at the first glance, this is the same patient. At first glance, everything appears to be okay. If there is a request for an intracardiac mass, we include in our protocol a venous phase, a delayed phase, to make sure that the defect persists in venous phase. Here's a left ventricular thrombus and a right atrial thrombus, all in the same patient. If you work in a heart transplant center or LVAS center, sometimes you will see layered thrombus like this in the cannula, and our heart failure colleagues refer to us all the time for this. Last but not the least, we can use our cardiac CT data to create 3D models. This is a particularly different model from most. I think it's, in my knowledge, is the only one that's hybrid because it's used a 3DT data set and a CT angio data set, and their Cartesian coordinates were co-registered, so we made sure to look at the same structures in both data sets. And we recreated, along with the company, 3D printing company Materialize, we recreated with the help of their software the whole mitral valve, papillary muscles, chordae, and leaflets. Whatever you see in blue comes from the 3D echo, whatever you see otherwise is from the CT data set. To come back, as I mentioned, education is key. I think education for our cardiovascular fellows and radiology fellows is critical to expose them to the benefits of cardiac CT as much as education of our medical community, talking to family medicine, talking to internal medicine, hospitalists, emergency room physicians, and showing them what cardiac CT is extremely important, as well as creating cardiac CT readers with enough expertise to provide quality interpretation. The more awareness we create of this modality, and I think it's a responsibility of physicians involving cardiac CT to increase this awareness, the more we will see this modality used in practice for the benefit of our patients. Last but not the least, it would be important to have recognition, like for instance, an example is the CMS code lacking for myocardial perfusion for all our work and all the benefits that cardiac CT provide to our patients. I would like to thank everybody as much as I would like to thank the staff I'm working with, without which none of these images would have been possible. Thank you everybody again.
Wonderful. Thank you so much, Dr. Catalin. That was a very fascinating talk. We did have a couple questions come on through the through the chat box. If Dr. Loghin and Dr. Chen wouldn't mind turning on their cameras and microphone, I'd love to go through those.
On.
Wonderful, thank you so much. Dr. Chen, are you able to join us? Well, he's logging on, Dr. Loghin. Let me ask you, what are your thoughts on FFR versus perfusion?
Well, the brief answer is I don't know. There's relatively limited data on the benefits and how to use and how to integrate each and every of them in our practice. Again, it's important to remember that CT-FFR talks about the discrete lesion, whereas myocardial perfusion speaks about the end product, what happens in the myocardium, in the whole myocardium, irrespective of what lesions are above, irrespective of or including collateral flow and so on. So they provide different kinds of information. It is arguable in either way. Is FFR valid? I showed you the comparison of the invasive FFR. Is it worthwhile stenting a lesion that has a CT-FFR without checking an invasive FFR? I think in real world, any interventional cardiologist will want to know if the invasive FFR is indeed as low as a CT-FFR. Going back on perfusion, is it worthwhile sending the cardiac catheterization any abnormal perfusion study? Based on the recent evidence, ischemia trial and so on, sounds like it's not. We can treat mild and moderate ischemia just conservatively. So I don't have a very clear path as to how to use each and every of them. I think every user or every institution should take advantage of the local expertise and get its own feel for how to go forward.
How do you determine when a patient gets scanned at a 4 cm versus a 16 cm scanner?
A 4 centimeter or 16 centimeter?
Yes.
Well, I suspect if you have 2 scanners, one 4 centimeter, one 6 centimeter, one 16 centimeter, you can have a choice. We don't, we only have the 16. So everybody gets scanned on the 16. But like I mentioned, even smaller size detector scanners, even the earlier generation scanners, 128 to 56, can still provide high quality diagnostic images. It's just not as easy, and it's not just in virtually every patient like a 16 centimeter scanner can do. You would want a slower heart rate, you want a regular heart rate. If I were to choose between a 75 beats a minute, very regular, and 60 beats a minute, very irregular, I would take the 75 beats a minute. And I'll scan that confidently on a smaller detector scanner, and I expect to see decent quality, diagnostic quality images. Now, if I want to do perfusion, I would certainly want to do a 16 centimeter scanner for the reasons I explained: temporal uniformity, one heartbeat acquisition, and so on. So that's how I would choose.
And we had somebody ask if you could repeat the correlation between CT-FFR and cath-FFR.
The correlation tends to fall exactly in the area that we're most interested in, 0.7, 0.8. So in other words, for clearly, angiographically, clearly non-significant stenosis, non-flow limiting stenosis, the correlation is perfect. Everybody agrees it's not a significant stenosis. Or for stenosis which are very tight, are clearly flow limiting, everybody agrees. CT-FFR and invasive FFR, they are both abnormal. The problem is exactly where it hurts. What happens to the intermediate borderline lesions? I have seen several cases, I can't speak of the FFR because I don't use it in our institution, but on perfusion where the anatomy was borderline for that stenosis, the perfusion was questionable. I sent the patient to cath, and the invasive FFR came about 0.81, 0.82. So it was, even that one was borderline. Similarly, I understand why the correlation for CT-FFR, invasive FFR tends to fall apart right in the 0.7, 0.8 area.
Dr. Chen, we have a question for you. With a higher heart rate threshold on a wide area CT, are there situations where you would exclude patients from cardiac CT?
Great question. So in general, I don't, if someone has a heart rate more than 100, I don't recommend doing a CT. I was pleasantly surprised that the case I showed you was an AFib case, and just happened that, we scanned it at a heart rate of 124. And, based on that, I might be willing to try doing some faster. I have some people in the 1-teens, but I would say probably general 120 and above. I try to shy away from CT.
Do you use the AICE or the PIQE across all your patients?
Yeah, so ACE and PEAK, these are the deep learning image reconstruction. So I routinely use ACE. So ACE is the first generation deep learning image reconstruction. So I routinely use that. We've been working with Catalin Medical on the next generation, which is a super resolution, which is PEAK. That one's FDA 510K pending right now. So we're evaluating that on a research basis.
Great. Now, just for both of you, with the new guidelines that make cardiac CT the frontline modality for chest pain assessment, do you envision cardiac CT will be used more routinely?
Dr. Chen?
Yeah, absolutely. I mean, that, now we have a multi-societal guideline, endorsed by many different societies that basically really puts the stamp of approval for using cardiac CT, and it does a very nice job in terms of delineating when it should be used and what all the available options are. I mean, everyone has options, but this one really now puts cardiac CT in many cases as a class 1 indication, which is great.
I as well think we're going to see an increase in the use of the modality. And I think it's going to be in parallel with our efforts to expose the medical community to what cardiac CT does. It's one thing to tell them, now we have a class 1A and a level A, class 1 and a level A of evidence for cardiac CT. It's another thing to show the actual images. I have an invariable response for whoever visits the reading room to see a cardiac CT. And the response is always the same. Oh, I never thought it can look this good. I never thought it can see all that. So I think if we use the new guidelines and the indication, class 1 is not that easy to achieve, and also try to show as many images as we can, we're going to see a definite increase in the use.
Wonderful. That is all the time we have for today. Thank you both for your time and your expertise. I really appreciate it. And if anyone has any further questions, you can reach out directly to info@cct.org and we will get it to the prep party. Thank you. Everybody have a wonderful rest of your day.
Thank you very much. It's been a pleasure.
Thank you.